Okay, so we have a MedPsych unit at Iowa, and the big idea is that if we could do concurrent and coordinated medical and psychiatric care, that theoretically it should be more efficient and effective than sequential care. And so patients should have both a medical and a psychiatric reason for admission. And delirium counts as both, even though nobody ever wants to claim it. Internal medicine wants to push it off on psychiatry, and psychiatry wants to push it off on internal medicine. But anyway, it counts as both. What we have here is a locked 15-bed unit. And because the outside door is locked, patients either have to consent to come in voluntarily, and so they can sign the voluntary form themselves, or if they're unable to sign the form and they have a durable power of attorney if they're unable to make a decision and they have a durable power of attorney for healthcare decisions, that person can sign them in. Or if they have guardianship papers, that person can sign them in, or else there has to be a court order. And there will be a psychiatrist on with all of you, and the unit clerk and the psychiatrist can help with those legal issues. That's not your realm of expertise. So we have 9 single rooms, 3 double rooms. One room has the capability to have negative airflow. All 15 beds have remote telemetry monitoring capability. And like I said, it's either a dually trained attending, or there will be a medicine and a psychiatry person that are co-attending. And the attending on-call pager is 5877. So you will have that pager it's a virtual pager, but you'll have it half of the time, and the psychiatry person will have it half of the time. The billing goes first. It goes through medicine, so if you've been billing online, you can still bill online. Otherwise, there's still the old form of just billing in the notebook. The resident should be writing internal medicine notes, and then you can co-sign the resident's notes. Just make sure they're internal medicine notes. And then the psych attending will do a separate note. There's a senior medicine resident or a med psych resident, and then there's 2 interns. The interns might be psych interns, they might be neuro interns, they might be preliminary medicine interns, they might be categorical medicine interns, they might be FP psych interns. You just don't know. You're going to get 2 interns. There's medical students that usually rotate on there. There's often some pharmacy students. We have a nurse manager and an assistant nurse manager. Marcia Gingrich is our nurse manager. She hasn't been around that much lately because she's up on 6-ray cover right now. And then Catherine Heath is our assistant nurse manager. And then we have a night float system with a senior medicine resident and a medicine intern that cover the unit at night. There's a nurse and a nursing assistant that work together as a team. The nurse and the nursing assistant, they cover 5 patients. So there's 3 nurses and 3 nursing assistants. They'll have 5 patients that they're assigned to, and they, like I said, they work as a team. We have an occupational therapist that's there Monday through Friday, a recreational therapist. We have a PharmD that rounds with the team Monday through Friday, a physical therapist that works with the med psych unit, a social worker, and then we have a trans aide. So I put their names up on there, and I can send you guys the PowerPoint if that's helpful. Otherwise, it's all posted on the unit. And the occupational therapist runs a coping skills group. They also can do activities of daily living assessment, or phys-diz assessments, or Allen testing, which is a measure of cognitive ability and can assist with discharge planning. The recreational therapist usually does 2 groups daily, one in the morning and one in the afternoon, but the occupational therapist and the recreational therapist, they won't come to see your patients unless the residents put an order specifically in for that. Likewise, the physical therapist, won't see the patients unless there's an order. And then, there's a registered dietitian that comes by. There's video monitoring in all the rooms and in the public areas. It's not recorded, but patients do need to be aware that there's video monitoring that's going on. It's for safety purposes. It's not because, we need to know everything that they're doing. We just want to make sure that it's a safe environment. There's a family visitation room. There's also an examination room where you can take patients back. If you need to do like a pap and pelvic, there's ophthalmoscope back there, otoscope back there. There's a dining room. There's a group and television room. We talked about the negative airflow room. And then there's also a restraint and seclusion room that's on the unit. Hopefully when you're there won't be any patients in that room, but we do have to have a restraint and seclusion room.
Just one?
We have to have one, yeah. We just have one on the inpatient psych units. They have 4 that they share between 2 units. We have a laundry room. Our washer's broken, but the TransAid just runs the clothes down to 2 Boyd Tower, uses their washer, and then brings the stuff up. And then we have there's showers in each of the rooms, but we also have a big shower room that has lift capabilities too. And then, just a nutrition room. A typical day, at 7 o'clock, the interns should already be here. They should be in the process of pre-rounding, and they also need to get handoff from the night float. And the handoff, should occur in person. And then at 7:30, the way that we have had it set up recently is that the night float presents any of the new admissions that have happened, over, the last 12 hours or whatever it happens to be. At 8 o'clock in the morning, we do a discharge huddle with the charge nurse, the social worker, the nurse manager, and the physicians. Just talk about which patients will be going today, which patients are ready to go, but we don't have a discharge destination for them, or maybe they need something that hasn't happened yet, and just try to see what we can do to facilitate that. The other thing that happens on MedPsych that's different than on other units is that on Tuesday mornings at 8 o'clock we do multidisciplinary rounds, and so that takes a lot longer. The room gets a lot more crowded because the occupational therapist and the rec therapist and everybody comes to those, and we go through a care plan on each patient and have to fill it out. Hopefully the psychiatrist that's there will fill out the form. I would just say it's their job. Then we round on patients. Around 11 o'clock, the senior resident will meet with the nurses and the nursing assistants, and they'll go over all the patients. By 11 o'clock, the team should have seen the patients. The nurses and nursing assistants should have already seen the patients. They just get back together to discuss any kinds of concerns or orders that maybe need to be discontinued, or orders that need to be put into the computer. And at 12 o'clock then, the residents need to be at noon conference. From the team on MedPsych admits every day. So there's no like golden days or post-call days. Every day is an admission day. The interns that are on the unit take admissions from 7 in the morning until 5 at night. If there's an admission that comes between 5 and 6, the night float senior is supposed to do it alone. And then at 6 o'clock, the night float intern comes, and the night float intern then can do the admissions with the senior night float. And So from 6 at night until 7 in the morning, the night float covers the med psych unit. They're the same night float that's covering hem-onc, which is at the other end of the hospital. And then the night float senior is also doing the surge co-management consults. And then on Saturdays, Sundays, and holidays, the night float senior comes at 7 in the morning, and so it should be the night float senior that's admitting with the intern. I know it gets kind of complicated.
Technology, night float is there all day.
Well, I don't know what else to call them, because when you look at Am I On, that's what they're called.
Yeah,
so the night float senior admits with a 3 Boyd Tower intern until 5 o'clock at night, and then it's the same as always. So there's always, so your intern, at least one intern, always has to stay every night until 6 o'clock, even if the work's been done like for hours. Is that clear enough on that? And then as far as admissions go, Super Triage accepts all the admissions from the ER, outside hospitals. They might call you, they might page you on the 5877 pager and say, hey, I just accepted Joe Smith down in the ER. If you want more information on this patient, call such and such a doctor or something like that. At night, they're supposed to call, like at the middle of the night, they're not supposed to call you, they're just supposed to talk to the night float. And then psych consults, the MICU, psych units, 6 Roy Carver, just make them call 4,000 or 5,000, and then that way you don't have to be dealing with like the waiting list and all those kinds of things. If the patient, sometimes patients are on inpatient psychiatric units and they get sick and they need to come to med psych, even though they're in the hospital, because they're coming to med psych, it's a brand new admission. If they're coming from any other unit, it's just you just need a transfer note and transfer orders. And then there's a med psych admission order set on Epic. It's pretty similar to the admission order sets that you might have used on 6 Roy Carver. There's just a couple of other things in there, like it has the psych activity level, the legal status, psychiatric precautions, and then some referrals for OT and AT. And then we use the symptom-triggered alcohol withdrawal protocol, which most everybody's using up on 6 Roy Carver as well. And I can show you the admission orders on Epic if you want to see them. The residents should know how to do it. A couple of things that you have to know is that patients aren't allowed to leave the unit unaccompanied. So whereas like on 6 Roy Carver, they might leave and go outside for a smoke, they might go down to the cafeteria with their family, they're not allowed to do that. It's a locked unit, they're behind locked doors for a reason. So they can't leave. There is a thing called a therapeutic leave of absence, and once again, the psych attending can help you with this. They have to have a psych activity of level 3, and their suicide risk scores must be assessed before they can go out on a therapeutic leave. If their risk score is too high, you really should reconsider before writing or having the residents write a TLOA or a therapeutic leave. We always ask people to ask about firearms on admission and firearms on discharge, and then we always ask the residents to ask about suicidality, homicidality, at admission and discharge. If you order neuropsych testing, we generally use the psych department for neuropsych testing, but you can use the neurology department if you want. It honestly doesn't matter. Use whichever department you want. They all train together, so it's not like one's better than the other. If patients should be on suicide precautions if they came in as a direct or indirect result of a suicide attempt, or if they're being admitted because of suicide risk or they're suicidal. And the nurses will probably talk to the residents and say, hey, I think this person needs to be on suicide precautions. The nurses are pretty savvy. If they think the person needs them, they probably do. That's not to say that you might want them on suicide precautions and the nurses think they're fine. I mean, I think if you want them on suicide precautions, put them on suicide precautions. But if the nurses are worried about something, they've got a reason that they're worried about it. And the other thing I wanted to talk to you about too is just some patients are there involuntarily and they might be committed or they might be on hold. Remember that the commitment only gives you permission to treat their psychiatric disorder, not their physical disorder. So if the patient's committed, you can force psychiatric medications or psychiatric treatment on them, but you still can't force medical treatment on them. Certainly, if you don't think that they can make a decision, you can always go and ask their next of kin or durable power of attorney. But just because somebody's committed for, let's say, schizophrenia and they have sepsis, you can't say, gosh, I'm going to force these antibiotics on you because you're committed. And I have the hospital attorney on speed dial, so sometimes I still have questions. But I mean, if you have questions, hospital legal can always help out. And remember that a durable power of attorney for healthcare decisions, remember that's only valid if the patient's unable to consent. And guardianship, you should always ask the guardian before you do things to those patients. It can get violent over there sometimes, but usually there's some kind of escalation that's happening. So if you intervene early, then a lot of times you can prevent the violence from happening. Certainly if you feel like you're in danger, don't be around there. I mean, just the nurses and the nursing assistants and the unit clerk and the trans aide, they're all trained in violence management, so they can de-escalate the situation. The psychiatric attending can de-escalate the situation. There's just like there's a code blue light, by everybody's bed, on the med psych unit there's a code green light that's by everybody's bed and out in the dining areas. So you can always push the code green button. It will alert people on the unit that you need help. So, and like I said, I can show you guys that, but if the code green button, it'll sound an alarm on the unit and people will come to help you. And I just put some phone numbers down if you need them. And I can write it all up on a piece of paper if that's helpful, or just send you this attachment. But just when I know there's an admission coming, I always talk to the senior and I let the senior talk to the intern. So I page the 9467 number, and I don't call the interns really. So that is it. I don't know anything else. I don't know if you guys have questions or anything.
Yeah, I have a little list here. How do you usually divide the pager halves? Do you do a week each, or do you just do it ad hoc?
So when I'm on, I just take the pager the whole time. Usually Kristen will send out an email and say, how do you guys, I noticed that the two of you are on, how do you want to divide it? A lot of times people do every other day. Sure. It's, now that the super triage system is here, you don't get called as often on that pager. It used to be that you'd get called day and night on it. Yeah, so I mean, if you say, gosh, I'd rather just take it all for a week, you can just work that out with the psych attending that you're on with.
Okay. And then do you usually As staff, do you come at 7:30 to staff the night float?
I do.
So you're there every morning?
Yep, and if that's something that doesn't work out with, if that's something that's just not going to work out, you just have to figure out a time when you can meet with the night float. They often have to go over to HEMONC to round on new admissions over there. HEMONC has a tendency to have their attendings come a little bit later. I don't know if it's, exactly what it is, but I'm always there at 7:30, and we just talk about the new admissions at 7:30, and then do the discharge huddle at 8, and then go and see the patients. And certainly if, nothing is like totally set in stone, so you guys will just have to kind of talk about it. But the residents do have to be done in time to get to conference at noon. I know maybe that doesn't always happen, but they really have to be done to get there.
Okay. And then if a patient is ready for discharge and says that they have firearms, and clearly like their suicidality, they don't endorse suicidality and homicidality, I would assume. What is the intervention? Like, okay, you have guns at home. Do I just document that, or do I need to do something further?
So we just so a lot of times patients will have guns. A lot of people hunt around here. If I'm worried about their safety, I just say, you know what, I don't feel safe sending you home while the guns are still there. Okay. Is there, can your folks lock them up? Can your son lock them up and take them somewhere? And then can you have this reassessed when you follow up? Okay.
Have you ever not discharged someone or held discharge because you can't deal with the issue of the guns, even though you don't consider them actively suicidal?
I have held discharge because guns were still in the house, but it was because I thought it was too dangerous to send the person home with guns. Okay. And hopefully the psychiatrist will do some of that assessment, because not that psychiatrists are any better than anyone else at predicting things, but it's more in their area of expertise and their normal questioning, and they're used to asking that.
Sure. Mm-hmm. Okay. And then the last question, I have a list here. In cases where someone have, say, schizophrenia and delirium, or you think that delirium is part of it, and since that is both a medical and a psychiatric diagnosis, how does that work if they're refusing treatment and you say that their delirium is due to their infection? Does that still fall under the medical, even though the delirium kind of becomes a unifying?
So we have argued that the delirium secondary to a medical illness, so we need to treat the medical illness, and the court has been okay with that. Okay. Just with sometimes you'll get an eating disorder patient over there that they're over on the unit maybe because their BMI is too low, or they're at high risk of refeeding syndrome, or they won't eat at all, and you can't get them to eat, and so you need to put an NG tube down. And that is kind of medical treatment, but it is for treatment of their psychiatric illness. So, okay. And certainly if there's questions that come up, you can always, talk to hospital legal. They're more than happy to talk about it. Sure. You can call me too. I might know the answer, I might not, but so. But